Welcome, everyone. My name is Yveris Martinez, and I direct the Center for Successful Aging here at Cal State Long Beach. It is my pleasure to welcome you all to our Colloquium Speakers Series. We try to hold several of these talks every semester just to bring together faculty, community members, students to learn about all the innovative and important work we're doing on aging in our community. Today we have Dr. Jackie Dawson from the Department of Physical Therapy presenting. Dr. Dawson has a PhD in biokinesiology from the University of Southern California, and her research interests are at the intersection of exercise science, computer science, and cardiometabolic disease. And today she will talk to us about optimizing exercise prescription for healthy aging. Just some housekeeping notes, I guess. You can use the chat box to introduce yourselves if you like, to drop some questions that you might have during the talk. But I think you'll talk for about, what, 30 minutes or so?
Yes, it should be like 30, 35
And
at the
then
most.
we'll have times for questions and answers. We'll also put in the chat box a link to a survey for feedback. We like to sort of get your feedback on how the talk went, what topics you'd like to learn about. So please take a few seconds to fill that out towards the end of the session. Okay, thank you. Go ahead, Jackie.
Thank you very much for having me here today, Yveris. As the title implies, I'm here to talk about the role of exercise in healthy aging. So I thought I would actually talk a little bit more about my role at Cal State Long Beach. I'm a faculty member in the Department of Physical Therapy, where I teach physical therapy students physiology, pharmacology, and exercise science. And in addition to teaching, I do research. And as Yveris mentioned, I examine the role of exercise in countering non-communicable diseases like cancer and cardiometabolic disease. My focus was previously on older adults, but I've recently expanded my research to younger and middle-aged adults as well. And I'm part of the biophysiology lab group in the College of Health and Human Services. So in speaking about healthy aging, I thought a good place to start could be examples of where people have been shown to live the longest and healthiest lives. And so these 5 regions of the world in Japan, Greece, Italy, Costa Rica, and right here in Loma Linda are known as the blue zones, where people have been observed to live well into their 90s and experience lower rates of non-communicable diseases. And while it's true that these regions share a strong sense of belonging within the elderly community and also share some of the same nutritional patterns, the one undeniable common factor to all of these regions is an active lifestyle that continues well into older age. So for example, in Okinawa, dance is an activity that's integrated into daily life, while in Sardinia, it's estimated that residents walk about 5 miles per day. But we know that healthy aging is more than just living for a long time. It's the longevity in the absence of disease and accompanied by physical and mental health. And this optimal longevity is termed health span. So ideally, we want our lifespan to primarily consist of health span. Health span is what enables independence and a high quality of life, which is what's been observed in the centenarians of those blue zones that I just mentioned. Now, multiple factors can influence healthy aging. Some are non-modifiable, like genetics, but many are within our control. And these are termed lifestyle factors, and they refer to the choices that are made regarding things like dietary intake, sleep, the choice of interacting socially, and also exercise. And of these lifestyle factors, exercise has tremendous potential for sustaining health span, which is why it's been identified as a primary strategy in healthy aging. Now, when people think about exercise, they tend to focus on muscle and how it changes in response to activity. And it's true that exercise has an immense effect on skeletal muscle. But the reason why exercise is so important to healthy aging is because it affects far more than muscle. Regular exercise leads to systemic molecular changes in pretty much all organ systems, including cardiopulmonary, musculoskeletal, neurological, endocrine, and the immune system. And exercise is the single most important factor for nearly all chronic diseases, and ample evidence demonstrates that regular exercise reduces all-cause mortality. And so this is why exercise is a key strategy in prolonging health span. Recommendations from the US Department of Health and Human Services indicate that older adults should be as physically active as possible and ideally meet the exercise targets that are shown here. And the first target is aerobic exercise, which can take any form, but should be performed at least at a moderate intensity for 150 minutes per week. So this could look like a fast walk for 30 minutes a day, 5 days per week. Muscle strengthening is next. This is of the major muscle groups, should be performed 2 days per week, along with balance and flexibility exercises. Now, all of this is a lot. These recommendations are a lot. And because it may be difficult to incorporate everything, doing what's called multi-component exercise is suggested. And this could be like playing a sport, tennis, for example, or taking a dance class or a boxing class, something that includes all of the components within one workout session. Now, it's possible that these recommendations are too advanced. And if an individual has a chronic condition that prevents them from participation, then just being as physically active as abilities allow is better than not being active at all. So how many older adults in the US meet these guidelines? In their latest report, which was published earlier this year, the Department of Health and Human Services found that less than 15% of adults age 65 and older actually meet the recommendations. And they also published reasons on why people might not be meeting the guidelines. And these are summarized as barriers to exercise. And the top 3 barriers to exercise for older adults are due to individual, external, or motivational factors. Individual factors refer to having a chronic health condition or physical limitation that makes exercise participation challenging. External factors are limited accessibility to an exercise space or limited access to a professional who can guide them on the exercise. And then third, motivational factors refer to the perception that it's too late in life to get started being active, not knowing how to do it, that's self-efficacy, and not having anybody to exercise with, that's lack of social support. So what I'd like to share with you today is how I, along with other investigators, have attempted to address these individual, external, and motivational barriers to exercise. So I'll be presenting findings from 3 intervention studies that I've either led or collaborated on. All 3 studies enrolled older adults into an exercise trial, and 2 of the 3 studies directly focused on older adults. And my goal in showing you these findings is to support how different exercise prescription and delivery can lead to positive outcomes related to aging. So the first study is a prostate cancer and exercise trial that I conducted as a doctoral student at USC. I was a student principal investigator, and I led the trial under the guidance of faculty in the Division of Biokinesiology and Physical Therapy, Dr. Christina Daly-Conright and Dr. Todd Schroeder. Also, 2 oncologists from USC Norris were an integral part of the study team and provided guidance. They were Dr. Tanya Dorff and Dr. Mitch Gross. This study was a 12-week resistance exercise intervention that enrolled 37 men diagnosed with prostate cancer who were receiving a particular treatment known as androgen deprivation therapy. So the exercise program aimed to improve several aspects of health that have been shown to decline due to the androgen deprivation therapy, and specifically cardiometabolic health, like blood biomarkers and body composition, also shown to decline as physical function, like muscle strength. And together, these can influence quality of life and mental health. So this study is an example of an exercise intervention directed at improving a chronic health condition. And most men who enrolled in the study didn't know what exercises would be best to do given their treatment and stage of cancer. And they were also unaware that performing resistance exercise would even be beneficial. So what I developed was a structured resistive exercise program that was performed 3 days per week for 12 weeks. The program targeted all major muscles. It began at a moderate intensity and progressed to a high intensity by the end of the 12 weeks. And in addition to the muscle strengthening, the men performed balance and flexibility exercises. Now, there were 2 study groups. One group received the exercise program immediately, while the other group performed flexibility exercises at home for the first 12 weeks, and then they were offered the full 12-week strengthening program. Now, the average age of participants was 67 years old, and most men had been on that cancer therapy, androgen deprivation therapy, for about 1 year. Now, in terms of adherence to the program, the exercise group was 88% adherent, meaning they attended 88% of all sessions offered and performed the exercises at the prescribed intensity and volume. The non-exercise group, this is the group that got the flexibility program, they were 79% adherent to their home-based flexibility sessions. Now, the primary aspect of health that we investigated in this trial were changes to cardiometabolic outcomes, specifically whether the individual had blood biomarkers, blood pressure, and body composition consistent with prediabetes, also known as metabolic syndrome. We also looked at sarcopenia, which is age-related loss of muscle. And before the intervention, there were similar numbers of people in each group with prediabetes or sarcopenia. But after the intervention, for the group that received the exercise, significantly less men were sarcopenic, meaning the exercise program helped them gain muscle mass. And in the non-exercise group, more men became sarcopenic after the 12 weeks. Now, with the pre-diabetes status, there was no change in the exercise group from pre to post intervention. So nobody got better, but nobody got worse. But in the non-exercise group, the number of participants with pre-diabetes did increase after the 12 weeks. So it appears that the exercise was most helpful in mitigating the muscle loss and could be more helpful in preventing the onset of diabetes. Next are the physical function findings. So here you're looking at changes in muscle strength as well as ability to walk a certain distance and stand up from a chair, turn around, and sit back down. So the exercise group improved in all measures of muscle strength. They also improved in the ability to stand up from the chair, walk a short distance, and return to sitting. That's called the timed up and go. On the other hand, the non-exercise group actually lost strength and they performed worse on the other physical function tests. As for mental health, the exercise group improved in certain aspects of well-being, so physical, social, emotional, and functional. There are other aspects to these questionnaires that were administered, but they did not improve fatigue or depression. On the other hand, the non-exercise group had no change in any of these outcomes, including well-being, fatigue, and depression after the 12 weeks. So taking these findings together, the resistance program that was developed for older men with a chronic health condition was able to improve multiple dimensions of health associated with healthy aging. In other words, what was once a barrier to exercise was overcome, but it did take a trained professional developing the program and other professionals carrying out the program. So the intervention was rather resource intensive, and one of the major limitations of the study was that such an exercise program might not be freely available in a community setting. And so this led to the next study that I conducted, this time at Cal State Long Beach, which is the CSULB M Health study. So this study aimed to make a similar exercise intervention more accessible to the community through remote delivery. And this was a randomized controlled trial that enrolled 84 inactive adults. Inactive was defined as performing less than 30 minutes per week of moderate to vigorous intensity activity at the time of enrollment. Participants were 18 to 85 years old, and they had to have a mobile device and high-speed internet access. I conducted the study with several great collaborators from LifeFit, Dr. Ayla Donlin, also from kinesiology, Alex Akira and Dr. Allison Eid, and from my own department, Dr. Sharon Tang. Now, the exercise aimed to improve cardiometabolic health. We took the strengthening protocol that was used in the prostate cancer and exercise study and adapted it to be more of a multi-component program. Then we implemented the intervention through remote technologies, including a wearable sensor, a mobile app, and video conferencing. And at the time, no one had used this particular combination of exercise prescription and delivery. So we conducted the study as a feasibility trial with secondary outcomes of adherence and quality of life. Another item to note about the study is that this trial was conducted over the pandemic from August 2020 to August 2021. So we were unable to collect in-person measurements, such as those that look at cardiometabolic health. So unfortunately, I don't have those outcomes to present to you. As for the intervention, this was a 3-arm intervention, meaning participants were randomized into one of 3 groups. Each group was built on each other in terms of the resources received. So participants randomized to level 1 only received the wearable sensor, a mobile app, and weekly progress emails with general health advice. The wearable allowed them to monitor their exercise intensity in real time and also to see the progress of other participants in that same study group, and they were able to interact with their study group. The level 2 group received everything that level 1 did, along with 3 pre-recorded exercise videos to follow along per week. And then last, the level 3 group received everything that the level 1 group did, but instead of the pre-recorded videos, level 3 took 3 group classes per week with an instructor over Zoom. An example of a training session in the intervention is shown here. As I mentioned, this was an 8-week intervention, and the exercise protocol was based off of the prostate cancer and exercise study protocol. It was adapted by reducing the rest periods and adding in what's called a circuit format, and including low impact aerobic exercise. So these changes made the intervention more of a multi-component exercise intervention that addressed these multiple aspects: resistance, aerobic, and flexibility training. And there were 3 exercise classes per week taught by a certified exercise instructor. And the intervention progressed in intensity every 2 weeks using target heart rate. So the target heart rate began at 70% of max and it increased to over 85% of max heart rate by week 8. Now, the overall mHealth trial compared feasibility between those study groups, between level 1, level 2, and level 3. But for the purposes of this talk, I'm presenting you with a sub-analysis of the data that compares outcomes for adults age 50 and over to adults aged 18 to 49. So we collapsed the groups and we're looking at outcomes based on age. So these are the baseline characteristics between the older and younger adults in the study. And there were no differences between these 2 groups other than age. So looking at exercise adherence first, which is again defined as both attendance, how many sessions were performed, and dose, at what intensity was the exercise performed, we can see that adults age 50 and over were more adherent than younger adults. Specifically, they performed more exercise sessions. They performed 32 sessions over the 8 weeks compared to only 14 in the younger adults. And they performed these exercise sessions at a much higher intensity, nearly 3 times the intensity, actually. And these differences are statistically significant. For quality of life results, we used a survey called SF36, where we found no differences in quality of life improvement between adults age 50 and over compared to the younger adults. We also asked participants what they enjoyed the most about the exercise program. And our qualitative results indicated that the social support they got from the program was the most valued aspect, regardless of age. However, the type of social support that was motivating differed between the age groups. For younger adults, the competition element of being in a group was motivating, and you can see that in this quote here. While for adults age 50 and over, the collaborative element or the community element was what was mentioned the most. So taking these findings together, this digital exercise program was developed to increase accessibility for communities who might not otherwise have access to these types of exercise programs. And we found that it was most successfully implemented in adults over the age of 50, meaning that using a mobile app with activity tracking encouraged exercise behavior change far more in adults over the age of 50 than under the age of 50. And it appeared that group interaction was key to facilitating motivation. For adults age 50 and over, the collaboration or sense of community was more motivating than competition. And the implications are that exercise programs like this that are fully remote or even hybrid can be more accessible, and they're also less resource intensive. However, it does require some technology literacy and high-speed internet access. This was not a problem for the 10 adults age 50 and older in our study, but could certainly be an issue outside of our very small sample. So the last study that I'll present findings from is the MeFit study, which was conducted in collaboration with American Gold Star Manor. Scott Ducharme was the PI on this study, and I was fortunate to collaborate with some of the same folks that I worked with on the mHealth study. So Dr. Ayla Donlan from LifeFit, as well as Alex Sakara. And then Claudia Huang from Human Development was also part of the study team. So this study was an 8-week on-site group exercise intervention that enrolled residents of American Gold Star Manor who were physically inactive at the time of enrollment. And the 8-week intervention is shown here. It's also very similar to the mHealth intervention, except that this was a 2-time-per-week intervention. It was taught in person by a certified exercise instructor. But again, it was multi-component in that it consisted of resistance exercise, so muscle strengthening, also low impact aerobic exercise, and then balance and flexibility training were included as well. The program was progressive, meaning that it increased in load in the weight used every 2 weeks, and intensity was monitored through the same types of devices that we used in the mHealth study. So the chest strap monitor, as well as the mobile app. Now, the outcomes that I'm going to present today for this study include the cardiometabolic health outcomes and the physical function outcomes. The study investigated more than that. It investigated physical function like gait, muscle strength, and aspects of quality of life, but I will not be presenting those today. So in terms of participants, we enrolled 10 adults who had an average age of 69 years. Participants were primarily female, and their compliance to the classes, there were 16 classes in total, was 83%. So looking at the results for the cardiometabolic outcomes, just to orient you to these graphs, the pre-intervention values are shown here in blue, the left-sided bar, while the post-intervention values are shown in green, the right-sided bar. Now, the cardiometabolic outcomes included glucose level, blood pressure, waist and hip circumference, weight, BMI, and body fat percentage. And we did not observe any significant changes from pre to post intervention for any of these cardiometabolic measures. And similarly, for changes in physical function, there were no significant findings after 8 weeks for a test known as the Short Physical Performance Battery, or the SPPB. The SPPB is actually a combination of 3 tests: a balance test, a gait velocity test, and a 5 times sitting up and standing from a chair. The scores on these individual tests are summed to create an overall score for the SPPB. So the higher the score, then the better the physical performance. We did not observe significance in the change in SPPB from pre to post intervention, but the score did increase. You could see that fairly clearly here. It did increase, and at a level that would be considered clinically meaningful for older adults. So it was above the minimal detectable change, or the MDC, which is 0.8. So it does appear that improvements were made, and they primarily came from improvements in balance and sit to stand. Now, we had also measured hand grip strength, and that same timed up and go test, which again is the ability to stand up, walk a short distance, and sit back down. We found significant improvement in the timed up and go, no change in the hand grip. But the improvement in the tug was small and actually would not be considered clinically meaningful, as the change was below the MDC. So taking these findings from the MeFit study together, it appears that group exercise can increase physical activity in older adults. We saw good compliance to the classes, so participants became more physically active than they were at baseline. It appears that the accountability was built through the social interaction of the group class. But there was no evidence for change in cardiometabolic health, and there was some evidence for improvement in physical function. Likely a longer intervention duration and monitoring beyond the 8 weeks is needed to see changes in these other outcomes. But one very positive result from doing this study is that the CSULB Life Fit Center is now providing contracted fitness services at American Gold Star Manor. So residents can continue to receive these classes, but no longer part of the study. So as for some concluding thoughts, my goal was to show you how multiple dimensions of aging can be improved through exercise. However, for older adults, it's not as easy as just stepping out the door and going for a run or going to a gym. So the exercise interventions that I presented aim to address some of these barriers to participation, listed here, as you can see: individual, external, and motivational factors. And we found that in-person, one-on-one strengthening programs are highly effective. They are able to improve multiple dimensions of healthy aging. Group exercise, whether in person or remotely delivered, is effective for some aspects, primarily motivation. But there are nuances with how long the intervention needs to be conducted and exactly what outcomes improve with those types of group classes. Probably the most important takeaway from these studies is that there isn't one best exercise prescription to do for older adults. So instead of trying to figure out, what exactly is the best thing to do, instead we should be trying to optimize delivery of the exercise in order to make it accessible and build motivation. Since the most successful exercise intervention is the one that the person will do and continue doing. So I would like to thank you for listening today. I just have a couple of acknowledgements here. Students that have helped with these studies, as well as American Gold Star Manor for allowing us to come in and deliver this intervention, and MyZone for supporting us with the devices. And so that's it. And I welcome any questions that you might have.
Do you mind on sharing so we can see each other all in the screen better?
Sounds good. Let me stop and share.
Lucy has a question.
I put it on the chat. if you would read it.
Sure. Let me get there. Okay. Let's see. In light of increased incidences of chronic illness, what would be the positive impact of daily walks of 1.5 miles if they did this weight-bearing exercise in their own community in terms of sustainability of the exercise program, as opposed to doing it in the gym setting? So I think that if I'm understanding this question correctly, we're asking, can we get some of these same benefits in doing this in the community? Do we have to go into a gym setting? Is
Correct.
that kind of, yes. So that is, kind of the whole point. Like, you don't have to be in a gym in order to see benefit of exercise. But however, if there is a chronic health condition where a specific element of fitness or health needs to be addressed, then that's going to be best done through a tailored program, such as the one that was done in the prostate cancer and exercise study, where we were very specifically trying to improve muscle mass to counter the therapy that was provided. But in absence of needing to address a particular target, walking out in the community is absolutely a great way of achieving these health benefits. And 1.5 mile walk is, it's profound. There's a lot of evidence suggesting that even doing, I forget the exact number, I think it's less than 30 minutes a day, but every day, can reduce mortality.
Yeah, because they cannot do aerobic. They older people, so that whereas they can walk.
Right, and walking is a form of aerobic exercise. So they might not be able to do the resistive exercise per se, but there is still a lot of benefit in doing aerobic. And I think what the recommendations are saying, to promote all around health, you do want that multi-component aspect. So the aerobic with the resistance, with the flexibility, but something is better than nothing. I guess that's what I would take out of those recommendations. A little bit of something's better than nothing.
I have a question. I think it was with the M Health study. The participants in this particular study were younger, even like the older adults were 50 plus. I can't remember the average age for the group, but how fit does an older adult need to be to start with this type of intervention? There needs to be a certain level of fitness.
There does. So I guess I will say that our inclusion criteria, we didn't want people exercising joining the study. So we actually screened out anybody who might have been doing exercise more than 30 minutes per week. And that included walking. So these were people who were inactive. However, as part of our exclusion criteria, we did exclude certain diseases or chronic conditions that would prevent a person from moving safely. And that was done, primarily out of a safety reason, because this was a remote intervention. We weren't able to see them in person. It was during the pandemic, all the labs were shut down. So we kind of had to put those exclusion criteria in. So some condition that would impair the ability to walk, for example, or a heart condition that was uncontrolled. These were all examples of exclusion criteria for that study. But we did want sedentary people to join us because we were trying to promote behavior change.
If there are no other people asking, I have 2 more questions. One is, you mentioned a couple of times quality of life change. Could you elaborate what that included? That's one. The other one is environmental. If you're following the LA Times, they found out that communities that have trees on the streets walk more than those communities that do not have trees, because you cannot walk when it's hot under the sun. Could you comment on that too?
Sure. Okay. So for the first question regarding what did we define as quality of life? So these were these were validated validated surveys that so they were validated for quality of life, and it depended on the study. One that we used across all studies was the SF-36, which assesses multiple dimensions, so physical quality of life, emotional quality of life. For the prostate cancer study, we used a cancer-specific quality of life instrument known as the FACT. We used one specific to prostate cancer and one just for cancer in general. And there were quality of life measurements in the NEFIT study. That was not an area that I focused on, so Dr. Huang would be able to comment on that more than I could. Now, for the second question regarding the environment.
Go there. And your study, there was no difference in the depression.
Right. For the cancer study, we did look at one measure of depression. So I'll say that so specifically what was observed was there was no difference in change in depression between the group that got exercise and not exercise.
You would think that with endorphins coming with exercise, there would be a difference.
I agree. I think that depression, and there are people who can probably speak on this more clearly than I can, but depression in chronic diseases that are potentially terminal, it's complex. And while the exercise intervention was helpful in the moment, there are so many factors involved. So what participants said, qualitative results suggest that exercise was a way for people to control, one thing that they can control in their life when so many things are out of control during cancer. So there was some benefit in that, but overall there was still negative self-thought around the chronic condition.
Natasha?
Hi, thank you very much for your presentation. It was really informative. I was just wondering, did you do any kind of follow-up afterwards to see what like the adherence levels were for people sticking to the program?
Yes, that is a great question. We did not do a follow-up period in any of the studies, actually. And that, again, is a limitation, one that's primarily driven by logistics. For one, I graduated and was not able to continue the study in that respect. And then with the mHealth study, we were able to transition back to in-person. So that study, as just being completely remote, ended. Now for the MEFIT study, one good thing that came out of this is American Gold Star Manor is now receiving those same exercise classes, but no longer as part of the study. So we aren't monitoring those participants. But it is, a potential for just tracking adherence is there, but we probably wouldn't be able to get the cardiometabolic health outcomes. But I agree that a follow-up would have made, the work much stronger.
Thank you.
I have another comment and a question, following up on Natasha's question about adherence, because I don't know what the literature says, but how sometimes people exercise and then for a period of their life, and then without the support, it's hard to kind of continue. Or there's some type of fatigue. I don't know why people stop exercise. That was so is there a way to, like, I guess what is known about what keeps people exercising and the drop-off rate in general?
Yeah, that is such a good question, because what we find is with these studies, one major criticism of these studies, especially from community groups, is that the intervention is great while it's here. And then when the investigators are done and they pack up and they leave, now how does it continue to be implemented? How do we keep the program sustainable? So, for my research, the switch to the group exercise was to try to address that, because if we can do a low cost, less resource intensive intervention, then potentially a community center can continue with this, whether it's like a YMCA or just a community center. Because yes, like typically adherence rates in we didn't look at it, but in other investigations, it is very poor after the intervention ends, and you don't have the contact with the study team. So numbers, if I can just pull out a statistic, it's usually closer to 30 to 40% adherence after the study ends, whereas we see good adherence would be 75% or above, which is what we typically have seen in our studies. So finding a way of keeping participants motivated. And we think that through the social support aspect that you get from the group class, so the communities that get built around, going and doing exercise, that's a key way of increasing motivation and therefore adherence.
Okay. And I can't recall if you said, was there a difference in terms of adherence between, or I mean, this was not part of your study, but you've done an online one and you've done an in-person group one. What are the pros and cons in terms of keeping people engaged?
Yes. So I would say out of the two, the remote version is more challenging. It is less resource intensive in the sense that the individual doesn't go on site, but it is more resource intensive in the sense that there is quite a bit of troubleshooting with the devices and with whatever the individual is using to take the class. And it's like learning. In-person learning is very different than online learning. There is magic in the in-person experience where you see people's reactions and experience it in real life. So the in-person group classes, I would expect to be more successful. We're not really comparing apples with apples between those two studies because the intervention was slightly different. And also for the in-person intervention, that was only 2 times per week, but we did a 3 times per week intervention. So that likely affected outcomes. But if resources were unlimited or less limited than a one-on-one, then the in-person group class would have the best advantage.
Okay. Natasha?
Yeah, I had one more question. Was there any kind of like an educational component to any of these studies where people really had a good idea of why and how it could help them?
Yes, I'm glad you brought that up. Thank you. The educational aspect was a big component of the mHealth study, and all participants in the study did receive weekly emails on general health advice. So everything like recommendations for exercise and healthy eating, nothing specific. So everybody in the study received that information. It was just the other 2 groups with increased behavioral support also got the videos or they got the Zoom class. But the baseline level of resource was the health advice, the mobile app, and the wearable sensor.
Okay, thanks.
Any other questions? Comments, ideas? Will you be publishing the MeFit results?
I think that is the goal. We just finished analyzing. The study finished up earlier this year, so we're in the data analysis and writing portion. I know that some of the investigators are potentially going to use it in a grant submission, and I imagine beyond that publication.
A reminder to those still online to please, Prarana put the link to our evaluation on the chat, and we can also email that to you if that's easier. Thank you, Jackie, for such a clear and informative presentation. I think we all learned a lot from it, and we appreciate your time and you sharing that with us.
Thank you all for having me.
Our next talk will be in November, and we will have Mark Godom from Memory Services of Alzheimer's Orange County, talking about some of the supports they're doing, particularly in Leisure World Seal Beach. So please try to join us then. We will probably send out that information soon, so you can join us. And thank you all for attending today.
Thank you.
All right. Have a good afternoon.